Hello, I'm Gian Antonio Rosti from Italy, and thank you for joining me and other members of this discussion round, Susan Sausen from Germany and Carla Bofinpani from Brazil, for this Touch Congress on optimizing treatment of CML in the first-line setting and beyond. We'll present and discuss insights from here, 2024, and from the recently EHA-iCML Foundation 2024 meeting in Prague. The first section, we have 3 sections today, is dedicated to the evolving paradigm of CML in the first line. The story of CML is a never-ending story. And we had recently the approval of asciminib and a couple of years before of ponatinib. And I discussed today even about olverembatinib, an additional TKI, currently approved only in China. So the situation is fascinating, is crowded, and is challenging when we have to decide the first line or further line of treatment. Currently, 1/3 of all the patients substantially fail their treatment due to resistance, intolerance, or frequently for a combination of both. The first trial I would like to discuss with you has been presented by Andreas Hohaus and is dealing with the ask for first trial with asciminib. Asciminib has been tested in a randomized fashion with the investigator selected TKI, meaning that investigators before randomization declare their TKI of interest for their patient. After randomization, one to asciminib and the selected TKI. This slide is summing up results, and results are clearly in favor of asciminib in dealing with the primary endpoint, which is the mesomolecular response at week 24. You see that asciminib versus all the remaining TKI, the rate of NMR is significantly superior, as well as testing asciminib results with the imatinib stratum, where the difference is of roughly 30%. So asciminib is an already well-known guy, and its most important characteristic probably is a good combination of efficacy from one side and safety. And in fact, in this first-line trial, adverse event leading to discontinuation were in 5% for asciminib treated and much more for imatinib and second-gen TKI treated. So asciminib is entering the first-line treatment scenario and approved in the US, and the process is on the way in other countries. The second abstract is newly dealing with the asciminib. It's a small trial. Alert CML was performed in US, 6 centers in US. You see that the number of patients is small because 36 presented at the European meeting last June, and 50 is the overall number of patients to be enrolled. I want only to underline that after 6 months of treatment, I agree, numbers are small, but the majority of the patients were beyond MR3 already by 6 months. And these results are in line with the results of other experiences with asciminib, and is another point to be discussed altogether at the end of this part of the presentation. finally, another frontline treatment who was very promising, ponatinib. And ponatinib, the results of this trial on 51 patients was from the MD Anderson Hospital presented. It's very active, and we all know already that ponatinib is a very efficient drug. By the way, after with a median observation of 13 months, the great majority of the patients reached a major molecular response, and half of them a deep molecular response. The problem is safety, and particularly cardiovascular safety, and we had 16% of incidence of cardiovascular problem, and 1 out of 10 patients permanently discontinue the treatment due to this adverse event. And now I can open our discussion with Susan Southwell and Carla Bocchimpani. I would like to ask, first of all, to Susan Southwell, looking to us for first study, once more, we had insights into the efficacy and safety of asciminib in the first-line setting. What are your thoughts on these results and how they might affect clinical practice in the future? Susan.
Thank you, Gian Antonio. I think the data from these ASCO First trial are very promising, and I was really surprised that the comparison of asciminib versus imatinib is so much in favor of asciminib, also in terms of not only in efficacy, which I I calculated with. However, with these side effects, it's so much better. In compared to second generation TKIs, there is also a trend that it's better with asciminib. So my impression is that this study can really change our first line indication and setting. So we need some more data. There are some other trials, but also the Australian study by Ehab Atala also demonstrated the efficacy at least.
Thank you, Susan. And you properly underline even other experience. Now, asciminib as it's a long story. The phase 1 trial now is at 7 years reported results. But this combination of efficacy and safety, and I would add a very good quality of life. I had a number of patients on asciminib, and what impressed me was really the absence of adverse event. This is the first point, and is bridging to the second question for Carla, because the alert of CML revealed or demonstrated the efficacy, the early efficacy of asciminib in inducing even deep response. What do you think about the efficacy and safety results so far? Do you think this will change when we see longer-term data and result for patients who also had lower dose TKIs?
Hi, Gian Antonio. It's a pleasure to be here. Hi, Susan. Asciminib is a very good drug. We have some patients using them, but I think that this is a good future. In this study, EHA-CML, we can see that the aim is to achieve more patients to enter or to achieving TFR, criteria to TFR. Then because of this, we can see that asciminib is fast to achieve the deeper molecular response. Then we can think that could be more other patients to achieving this criteria. That then about this we can thinking that we will have more success or more patients having success in TFR criteria. I think that this will change our practical, because nowadays we think that to achieve TFR is an aim in treating patients with CML, and not only for the pregnant patients or the women that would be want to be pregnant, but perhaps some patients that will have less adverse events achieving TFR. Then I think that this could be a criteria to change our protocol.
Thank you, Cara. And it's even my thought that we were so attracted by TFR, of course, but no doubt that second generation TKIs, dasatinib and nilotinib, produced much more deep molecular responses and then prospectively more TFR. But we paid, I mean, the patient paid in terms of toxicity, and particularly with nilotinib. So having a drug safe, okay, the final word for safety of asciminib still to be defined, but anyway, with this life of asciminib, so I mean 5-7 years, apparently is a safe drug. A safe drug and so efficient in inducing deep molecular response. Probably will change newly paradigm for TFR expectation for our patient. The superiority with imatinib is clear. In the same trial were presented results compared the comparison between asciminib and second-gen TKI. From this point of view, results are not so different, but once more, asciminib is able to give us same results achieved with second-gen TKI, but paying much less in terms of toxicity. So this will be defined in coming years, but this is really very, very, very exciting. So ponatinib, we have 10 years of follow-up for ponatinib in newly diagnosed patient because ponatinib was tested even in earlier years in front line, but then the development of the drug in first line was stopped by FDA due to an excess of cardiovascular toxicity. What are your thoughts on the risk-benefit profile of ponatinib in front line? Is a story to be completely forgotten, or is there some space maybe in a selected patient population? Susan?
Actually, I think in first line, the story is over for ponatinib at the moment, at least. So I do never know what happens. However, I don't think that they make any trial anymore due to the risk-benefit profile. If you look at the data in detail, I think it seems a little bit that ponatinib is could be more effective. However, there's no direct comparison, so it's only an estimation of out of the data. And I think it could be a little bit more potent. However, the side effects are difficult, so you really have to select patients too much to really go frontline in each patient for it. But I think that ponatinib is a good drug. You know, we will have probably asciminib in first line in a lot of patients in the future. So you have to think what to do with patients who are resistant to asciminib. Or so I think that's a good backup drug, and it's important that we have it, and we have to go on with it.
Thank you. I share, I mean, the same perception, maybe that in the future as a second line treatment, but front line ponatinib probably is an ended story already. So I believe we can move forward with the next section of our discussion, and discussing about second and later line of treatment. And from this point of view, we made the choice of 5 abstracts, and the first one is dedicated to ponatinib, and Jane Apperly presented it last year, 4-year results of the OPTIC trial, but only selecting patients bearing a T359 mutation, 67. You will remember that the OPTIC trial is a randomized prospective trial in multi-resistant patients, randomized to receive 45, 30, or 15 milligrams of ponatinib, and reducing the dose of 45 to 30 and 30 to 15 once a response has been achieved. A dose optimization trial dedicated to reduce the chance of cardiovascular event. Looking at the T359 mutation, here the starting dose is 45 milligram and is convincingly better in terms of response, less than 1%, in terms of progression-free survival. Overall survival is, you see, less different numerically with respect to the 30 milligram and 50 milligram arm. 45 milligram starting dose, but reducing the dose of ponatinib from 45 to 30 and 15 reduce even the chance of achieving retrieving a treatment emergent arterial obstructive event. Just to be remembered that once you have to reduce the dose of 45 milligrams of ponatinib in case of the mutation, the 315 mutation, do that slowly, because the risk of losing the response when the 315 mutation is present is higher with respect to our other setting. The second aspect I'd like to present is dedicated to the dose of bosutinib. You know well that the right dose of a TKI in any single patient is very difficult to be defined. But this is a Japanese trial that Kimura presented at the last European Congress. And the endpoint of this trial was simply to demonstrate a reduction of grade 3 or 4 adverse event, not prospectively, but they compared their experience with a previous trial, Japanese trial, with 500 milligram. And this is a further demonstration that whenever you decide to start bosutinib in a new patient, you should start at a lower dose at 500, 200, and then going up, if necessary, until 4 or very infrequently to 500, but along the way of treatment. And you see that the treatment discontinuation is in 11% of the patients, so 1/3 with respect to starting 1500 milligrams. This is a new field of clinical research, and I believe that for bosutinib, other similar trials have been published. One from Italy, best one from Germany, the Bodo trial, if I remember well. All of them dedicated to mitigate, particularly the gastrointestinal adverse event, which bosutinib given straight 4 or 500 milligram daily, gave to the patient. And another aspect presented by Paul Lerosé is a German trial, the touchIME trial. Is another way to mitigate, in this case, adverse event of dasatinib. And this trial, the design is very simple. So giving 100 milligram 5 days a week instead of daily administration, an experimental arm and a standard arm. And the comparison, you see the data, that first-line patient, for example, in terms of major molecular response at 24 months, absolutely the same, even any treatment line. So this weekend holidays did not jeopardize the results of dasatinib. but reduce significantly the incidence of, the most frequent, even in the long-term adverse event of dasatinib, which is pleural effusion. And you see that the incidence of pleural effusion was 50% with respect of the standard way of giving dasatinib daily. In this case, we can dolly this. So another way to improve the overall outlook of treatment result with dasatinib. Does it 5/7 of dasatinib 100? And at the recent ESH meeting, the EHA Foundation meeting in Prague, Kim presented a huge trial with, you see the numbers, 300 of patients treated with asciminib and 300 with ponatinib. Is a worldwide analysis, registry analysis, to, I'm saying, compare, but of course is not a direct comparison because these data are coming from different experience and different countries. In terms of event rate over time, just if you pay attention to the propensity score matched analysis patient, you see that asciminib is superior, and even in terms of failure-free survival at 12 months, where the PSMA patients treated with asciminib did better. This is interesting and suscitating discussion, because no doubt that when a patient is failing more than 2 drugs before, the choice of the further line needs to be taken upon the patient we have in front, comorbidities and type of resistance. Really challenging, but another piece of information for everybody. Further on, this new, not a new TKI, at least for us, because olverembatinib is registered so far only in China, but trials are running to promote this registration in other countries. Here's a book here that presents results of a number of patients treated, pre-treated, hugely pre-treated, even including ponatinib and asciminib, where olverembatinib showed, a good outcome from the efficacy point of view. And you see that patients achieving even a major molecular response after having failed drugs and ponatinib and adding asciminib. 1/3 of them responded properly with the safety profile, which is, promising good things even for the future. So we'll see in next years which will be the future of olverembatinib, at least in chronic phase CML. Now I can turn back to challenge Carla and Suzanne with some questions. The first one is for Carla. We have all seen the 4-year efficacy of ponatinib in the OPTIC trial in patient bearing the T359 mutation. Asciminib will have data to be presented later, but 200 milligram daily has a shorter story, but very good results, particularly in patient naive of ponatinib. So what are your thoughts about? Do you think that will change when we see longer term data for asciminib? Carla, please.
Good, Gian Antonio. Thank you for the question. Ponatinib is classic. Then we know that this is a potent drug. That's the design of OPTIC is very interesting because the design of OPTIC tried to grown down the adverse event, the cardiovascular event, then this was a very good idea. But we are knowing now asciminib and asciminib 200 milligrams. We saw the last presentation in the last meeting of ICML Foundation that asciminib 200 milligrams is better or is safer and achieve a very good response against the 315 mutation. Then I think that now we cannot tell that the asciminib is better than ponatinib because we don't have this comparison in 315 mutation. We will see that the King showed a presentation about this, but we need more time to achieve in the real world presentation. But thinking about the optic study, ponatinib is very good. But the problem with ponatinib, we know that is the adverse event, the cardiovascular adverse event. The asciminib 200 milligrams achieved very good response against the 315 and it's safer. Then it's difficult to speak that is better, but we had two very good information that asciminib is very good, is very safer, is efficacious, have a very good efficacy. We can use asciminib achieving very good response after ponatinib. Then this is a very good scenario because we can use asciminib first ponatinib and we can use asciminib after the ponatinib. We can use both drugs. We can use the safer drug first, and you can achieve more efficacy results after two.
Thank you, Carla. Susan, my question for you it probably will require 1 week to answer properly, but reduced dose of TKI, I mean, the bosutinib, the BOGI trial and others, what are your thoughts? Are we arriving with this information too late or it is not too late?
I think it's not too late. We have made the German trial on dasatinib with reduced dosing. So I think my message is that you probably, first of all, I think the trial design in clinical trials to get the right dosage might be not the correct one the phase 1 trials are also focusing on DLTs and then you get the highest dosage where DLTs are not there. So probably that's not the right schedule how to define a perfect dosage of a drug.
Yeah.
And so we now go a step back, like in other diseases, not only in CML. And my experience is exactly, for example, from the BOGI trial, that when I start a patient on bosutinib, I usually start with 200 milligrams and test, if he stands 300, and we end in most cases with 300 milligram because 400 milligram is not tolerable, and.
Yeah.
But it's still very effective. And that's, you can't go back with phase 1 trials. However, it's difficult then to define and it's expensive to define in new trials what is the optimal dose.
That is my question to Carla. As dedicated to the propensity score mesh analysis of asciminib versus ponatinib, probably I believe that in every single country it is important even to analyze the real world experience of their country, of their region, because the differences existing between countries, they are reflected even in terms of efficacy and toxicity of asciminib and ponatinib in this case. Carla, just you want to comment about this topic, Carla?
Very good, Gian Antonio. I saw this presentation from King, and very interesting. A huge number of the patients, and these paper about the real world is very interesting because we need to understand, as you said, which the scenario in each country, because it's very different, the people there, and this real world is very comes us to the true reality that the patient using these drugs. And we can understand that PSMA was very good to do to put the two drugs in the same group like this, not comparing so efficacy, but this turning them these two drugs to the same patients using in the same scenario. Then we can saw that the comparison and asciminib was better, if more efficacy and more safer, comparing asciminib to ponatinib, but not in 315 mutation. Then this thinking about talking in last minutes, the 315 we can choose each one, and very good if you can choose the safer drug, okay. But in all other patients without 315, asciminib was better.
Can I add a comment? Because I think,
Sure.
I was also at this presentation, and from my point of view, we have a little bit cautious with this analysis, because it's there was also some discussion on the matching, and I think we have to wait for the full paper if this still stands. Yeah, because I remember that there were some two aspects which I think they should recalculate if it's really okay, like they matched the patient. So we wait for the full paper. At least that's my message from that. Yeah.
And that though, Susan, I mean, a prognostication of the future of olverembatinib. Now it's in China for resistance CML and even ALL. That I see that probably will be a further option in Western countries. Susan, which is your thought?
Yes, actually, the data they presented are very interesting in terms of efficacy after ponatinib and asciminib treatment. However, I think we need a trial, and I know the company is planning a trial in Europe, and I don't know, also in your country, Carla. The pity is a little bit that the comparator in this phase 3 trial is chosen as bosutinib 500 milligrams, which I think it's not the best comparator. And so with these data, you don't know what to do. And however, we have to wait what they do. We need this phase 2 trial in Europe and in other countries to really judge if this is also not in Chinese people like that, as you mentioned before.
Yeah.
Yeah.
Thank you. And now the third and last section, titled How might the emerging data for current and investigational TKI for CML influence the treatment of the patient now and in the future? I'd like to present, first of all, the long-term follow-up of the STEAM trial, the French trial, stopping TKI in a 100 patient, and the very long follow-up of this patient, and the molecular recurrence-free survival at 10 years was 37%. At 156 months, remain almost the same. So 1/3 of the patients in the very long term are, facing, I would say, the beloved definition from John Goldman of operational cure of CML. Another article presented at Madrid from the Czech Infinity Registry on 1,000 of patients, so it's nationwide analysis, and comparing the TKI efficacy in matched treatment group. You see the matched are 163 for nilotinib and imatinib, but faster responses with nilotinib, but the same long-term effect in long-term survival, very good for both, but when imatinib is a very good choice still, no doubt. Then Orwe-Cortez presented in Prague at the ESH 2024 meeting the 6 years analysis of ASHIME, the phase 1 of ASHIME, 200 twice daily in a patient being the T315 mutation. And you see, as already we discussed before, that in ponatinib naive 19 patients, the rate of cumulative major molecular response over time was very high, 74, but still good responses even in those who failed prior ponatinib, 40% of major molecular responses. With an overall safety profile good. Only, I mean, in few cases it was necessary to stop definitely ASHIME, but this is a characteristic of ASHIME, the ability of the patient or the doctors to carry on the treatment in the long term. Further on, an analysis presented by Leszke at ESH in Prague recently, dealing with mutations affecting response to asciminib. We have, mutation with strongly decreased binding affinity, the so-called specific myristoyl pocket mutation, like A337T, and others like N244V and F359I, they live and change the binding affinity of asciminib, but able to affect resistance to asciminib for these cells. So even translational studies are looking at the potential point of resistance of asciminib, and in this cartoon is offering the potential solution in case of mutation. When specific for asciminib, switch to NATP competitive. In other instances, like M244V, the option to dose escalate or to switch. This is to be confirmed in clinical trial. And finally, F359WND, challenging not ilotinib, not imatinib, but dasatinib or ponatinib as a further option. Really exciting and challenging. Sweet presented the results of a phase 2 trial at the last year. They added in a phase 2 randomized patient ruxolitinib in addition to the classical TKI used in patient with detectable leukemia. The point was to change and disrupt the hospitality of the bone marrow niche for the leukemic stem cell, and to letting the TKI giving deeper responses. And apparently it is, you see that in single agent or the adding of ruxolitinib 15 milligram daily, the schedule with a significantly higher major molecular response rate. And last, but I would say not least, Fabian Lang from Frankfurt presented in Prague results of preliminary results for safety and efficacy of EHA-1. This is not a classical TKI inhibitor because it defines the best in class because it's a type 1 binder, so go straight to unfolded BCR-ABL, and absence of off-target effect. It's a very attractive drug, and in this phase 1 trial with median exposure of 20 weeks, so it's a very young experience. Clinical adverse event were seen in very few instances, and by the way, a proportion of patients heavily pretreated achieve the major molecular response. If this is another very interesting drug, will be added to our treatment armamentarium. I'm sure. Few short questions to both Susan and Carla. A comment from Susan, who is an international expert on treatment-free remission, world expert of treatment-free remission. A comment about the STEAM trial.
Yes, thank you, Gianantonio. I absolutely, confirm that TFR is a really treatment goal in most of my patients, not only in young one, as we discussed earlier, also in patients who are older, because, if a patient has a life expectancy of at least 5 years or more, also older patients will really profit of a TFR if you can stop the TKI later on. Also, if you look at the interaction with other medication, which older patients need much more than younger one. And so I'm absolutely looking that patients come to TFR in any case.
Thank you, Susan, and share your perception. And to Carla, is imatinib the preferred frontline treatment in Brazil? So far, commenting even the Czech registry where nilotinib at the end gave same responses, or second general very popular still?
The registry was very interesting, the presentation. In Brazil, we have a registry too. We have some problems to assess. We've assessed the drugs because we have in Brazil two systems, the public system and the private system. In the public system, we only can use imatinib in first line. In private system, we can use imatinib or nilotinib, but nilotinib only if the patient is so-called high risk. Then if the patient's not high risk, we cannot use nilotinib in first line. We have some problems with this access. But this paper, very interesting because we can see that nilotinib is faster, but the finish of the end of the way, the buff drugs can achieve the same results. Then we have the imatinib, that's very safe drug, and we can use nilotinib if you want a deeper molecular response faster, like the patients that would like to be pregnant and get pregnant in some day. Then I think that this is interesting, and we know that nilotinib is a drug with more adverse event, cardiovascular adverse event. Then because of this, perhaps we can understand that using imatinib in first line is a good option in all the patients.
Thank you, Cara. And for you, Susan. At ASH we had long-term data about the phase 1 trial of ASH of ESH-iMLf. But your comment: for how long should we wait to define ESH-iMLf really a safe drug like imatinib is? I understand this is probably in part a foolish question, but I want to know your thought about safety of ESH-iMLf.
We have so long experience now in these phase 1 trial patients. It's more than 10 years, I think, yes, or even 10 years. And I think also the number is not so high. When we remember back the story about nilotinib or ponatinib, we very fast knew that there could be some problems. However, we didn't realize it's so good due to some I can't remember very well, but I think the first alerts on nilotinib came quite in 2009, but really were published only in 2011 or so. And the study started in 2007, so there was a 2-3 year interval only, and no one expected any treatment-related vascular events. So I think the time is already gone with asciminib in that case. So I feel quite safe with the drug. and you never know what comes up. But in these patients, you should have had some alerts at least on that topic.
Totally agree with you from this point of view, Susan. What are main data from presented at ESH with a specific and the new way to post resistance to asciminib? A comment about asciminib and mutational status, Carla.
Okay. Very interesting too. We can see we can understand that asciminib is a different drug. Asciminib is blocking the other place, now the site, the myristoyl pocket. Then we can understand that we have mutation against the myristoyl pocket, and we have this mutation with different grade of binding the affinity in these pockets. Then we have other mutations that are not against the myristoyl pockets or perhaps against in other places, and these mutations are influencing the results using asciminib. Then, because of this, mutation is very important to lead us to choose the drug or to increase the dose or to switch the drug or to add other drug. This is very interesting with asciminib because we can use adding other drugs, and because of this we can add drugs against the myristoyl pocket, asciminib, with drugs against the other places that the mutation are working. And but we need to have access to this exam. Then sometimes we can see that mutation is not so easy to do this exam in all the countries. Then for us, we need to have access to do the exam in all patients that are losing the response or that don't achieving response with asciminib, and we can add other drugs or increase the dose. Then this will change our management with the drug.
So, Susan, I posed the last two questions to you simultaneously, asking you for a short and straight answer. Is the future of combination treatment in CML, TKI plus something else still bright, or is it black sky from this point of view? And second, I was fascinated by the results of the EHA the so-called best TKI inhibitor so far, at least on the paper.
Okay. Yeah, thank you. I think combination treatments are absolutely interesting in patients who do not make it in deep molecular remissions or who are just above 1% or so, and who have no, you don't want to go for a stem cell transplantation, because I think in these patients, there are BCR-ABL independent pathways which you can hit with these studies and combination this was done with ruxolitinib. But the data are really convincing, and what she demonstrated is that the response was durable. The ruxolitinib was added for only 12 months, but the response was then durable for another years, and some of them really went in TFR. So I think that's a promising approach. And for the ELVN and Livin study, I think for sure, every TKI we have on hand who has less side effects as the ones we have at the moment is important for us to treat our patients in a perfect way. And I think the data are very promising. We also have some patients in that study, and it works really good. So I'm quite optimistic that the drug will make it to registration.
Thank you, Susan, and thank you, Carla.
Thank you, Gian Antonio.
Thank you. A great pleasure. Thank you, Susan. Very, very great to pleasure you again.